Welcome, everyone, to the first of many to come expert led large group supervisions sessions here at Resilient Mind Psychotherapy. Today's guest is Dr. David Elliott, a psychotherapist, professor, and one of the world's leading experts on adult attachment. He received his Ph.D. in psychology from Harvard University and completed a postdoctoral fellowship at McLean Hospital. He is also the co author of Attachment Disturbances in Adults Treatment for Comprehensive Repair, a groundbreaking work that introduced the three pillars model, a clinically tested and highly effective approach to healing insecure attachment in adults. Building on decades of research and clinical experience, Dr. Elliott helped develop what is now known as Integrative Attachment Therapy, an evidence based framework that blends psychodynamic, somatic, and cognitive behavioral principles to support deep psychological repair and emotional development. He teaches these methods internationally, training psychotherapists, counselors, mental health professionals in how to repair core attachment injuries, foster earned secure attachment, and help clients feel safe to open, trust, and love again. Dr. David Elliott, the floor is all yours.
Wonderful. Thank you, Artem. And it's great to see everybody, and especially knowing it's a lovely summer morning, and here you are starting your day with this gathering, and hopefully being interested and benefiting from what I'll share today. So yeah, I just want to take a moment and take everybody in and arrive fully. So the field of attachment in the area of psychology, of course, is huge. There's been so much written about it, so much interest in it in the last years. So I assume that you all have some basic understanding about attachment issues, about what it is, how it may show up in our work, in our psychotherapeutic work with clients or patients. How many of you, just raise your hands, feel that you have a really good understanding of attachment and attachment dynamics? Yeah, yeah. So what I'd like to do is just present in the for the purposes of being able to talk more fully and deeply about the three pillars method and integrative attachment therapy. I'd like to present a little bit of context about attachment theory. And just, again, it's a huge field, but I'd like to just point out or highlight a few key principles that are the foundations for what led to the development of the integrative attachment therapy approach, and why we believe that it's really helpful and really effective. So the most basic elements of attachment theory are that we're born with an innate instinctual drive that orients us toward caregivers. Okay, our survival is benefited if we have built within us a tendency right from birth to orient toward who hopefully will be able to meet our basic needs, our basic survival needs. Now, if all goes well and those basic needs are met to a reasonable degree, there will develop a mutually beneficial bond between the infant and the caregiver or caregivers. That bond is called the attachment bond. Now, as the child develops with a positive, secure attachment bond, there will be an internalization of that experience, which then leads the child to expect that whenever needs will arise in the future, those needs will likely be met to a reasonable degree. Okay? It's a sense that if you're familiar with Erik Erikson's work, it has to do with basic trust. Erikson considered that basic trust versus mistrust is the first developmental task that we all encounter and are all faced with. Are we going to trust in the attachment sense that our caregivers will be available to us when we have needs, or are we not going to trust that? This is a foundation for our experience in the world because When we're infants, the caregiver or caregivers are the world, essentially. So whatever we experience with the caregivers will get internalized and affect how we're looking at and how we experience the world around us. Now, a basic trust and a sense of secure attachment is a foundation for healthy development. Neuroscience research has highlighted that the brain develops faster, more efficiently, in a more integrated way in infants who have a secure attachment bond. Now, the insecure attachment bond occurs when the child's basic needs are not met to a reasonable degree. And you've heard me say so far a number of times, reasonable degree, reasonably expect. This principle basically is Donald Winnicott's notion of good enough. Okay, we're not looking for perfection in parenting. We're not looking for perfection of experience that the infant will have. Like everything is absolutely right. But good enough is good enough. Good enough is actually best because it's important that caregivers sometimes are not immediately available. It's important that sometimes an infant will be frustrated. If an infant's needs are always met 100% of the time, right away, that infant and growing child won't learn frustration tolerance. So good enough and reasonably available caregivers means basic needs are met to a sufficient degree that allows satisfaction of needs, a sense of trust that needs will be met, and also an optimal level of frustration and difficulty so that the child will be able to learn that the world will present circumstances that are not always easy. Okay. Now, if the caregivers are not good enough in this model, if the child too often experiences too much frustration, hurt, lack of needs being met, then the basic mistrust will develop. There will be some form of insecurity about the world, about the caregiver relationship with the caregiver, and the sense of being in the world. When that occurs, the infant will find, and developing child will find ways to try to cope and adapt with those circumstances. Now, there's several basic forms of coping that seem to be built within us. And these are the three primary forms of insecurity in the psychological domain. So if we think about this innate drive within us that John Bowlby called the attachment behavioral system, when that is frustrated, when the needs are not, when the caregiver isn't sufficiently available, there will be an enhancement or a hyper arousal of the attachment behavioral system. The infant will not trust that the caregiver will be available and will seek that caregiver excessively, will try to capture the caregiver's attention with a sense of anxiety, basically, tension, stress, that the caregiver is not going to be available, that the infant learns that there has to be extra focus, perhaps on meeting the caregiver's needs, so that the caregiver will be reasonably available for the child. Now, if in the context of the attachment system, the child experienced active rejection by the caregiver, then that will mean that the attachment activation is scary. If I am drawn to somebody to be closer, and I have an internal expectation that that person will reject me, then I will feel uncomfortable about approaching the other, and I might stay away. I might deactivate the attachment system. There will be a hypoarousal, a reduction of that attachment system. So the third adaptation involves when there's a confusing set of circumstances for the child. Sometimes the caregivers are really there. Sometimes there's abuse, perhaps. there'll be both, there'll be a mix of a hyperarousal and a hypoarousal of the attachment system. And this is commonly, when it's present in a child and in a later adult, this is typically referred to as the disorganized form of insecure attachment, or the fearful form of insecure attachment. The hyperarousal tends to be called the anxious preoccupied insecure form. The hypoarousal tends to be called the dismissing or the avoidant pattern. Now, these patterns, these adaptations, although they can help the child cope with the immediate stress and distress of the attachment relationship, the attachment experience, those adaptations actually have developmental consequences. Okay, again, as I said earlier, the brain develops more rapidly, more efficiently, in a more integrated way when there's security. Various developmental lines also develop more effectively, more efficiently, more quickly when there's security. So the relational developmental line, the self-developmental line, that includes self-identity, self-esteem, self-agency, sort of acting from one's own self-needs. All of those will benefit from security, and all of those will be affected in problematic ways when there's insecurity. Now, in the United States, research has estimated that over 40% of adults have some form of insecure attachment. When you think about that, that's a huge number of people. Now, and that's measurable attachment insecurity. The whole domain of assessment, how to assess it, that's a big area and somewhat controversial, but it's reasonable to collect the evidence that is available and say that over 40% of Americans have insecure attachment. If we think of the psychotherapy world in our work and who we encounter in our work, research highlights that the majority of people who come to psychotherapy have some underlying attachment insecurity, even if that's what they're not overtly coming to therapy for, to address. In underlying attachment insecurity makes us all more vulnerable to developing psychological problems. So we're more vulnerable to developing anxiety, depression, relationship problems. If someone experiences early trauma, if that trauma occurred to them when they were secure, the consequences of that trauma are less problematic than with a child who experiences trauma or some form of abuse when they were insecure. Okay, so somebody coming to therapy for help with a post-traumatic condition, if we pay attention to the attachment dynamics that underlie that, that will help guide our treatment of how to most effectively work with the presentation of the post-traumatic condition. So if the person has underlying security, but comes for help with some post-traumatic condition, we can rather directly work with the trauma. We can apply the evidence-based models and methods that suggest that exposure-based work can be very, very helpful. Because when someone has when someone has a secure basic attachment system, then they're more resilient. They're more able to experience and process more directly challenging material. Okay, so an exposure-based trauma treatment can be effective with somebody who has a secure base, essentially. But it's interesting, the research literature on trauma treatment that has validated that the exposure-based treatments are quite effective always report that a significant minority of patients don't do well with the exposure-based treatments, and some of them actually get worse. My understanding of that is that those people who get worse with exposure-based treatment are people who have underlying attachment insecurity, which means that their psyche, their emotion system, their emotion regulation system is not stable. It's less resilient. It's more vulnerable to disruption. So if you present someone with, having them remember traumas too soon when they have an insecure base, they're likely to get triggered and overwhelmed by that and actually do worse. So in my work and in my looking into this, all of this, these considerations, if someone comes for trauma treatment, to therapy for trauma treatment, and we assess that they have an insecure attachment dynamic, it's really helpful, and I'd say really important therapeutically, to address the underlying insecurity first before addressing directly any of the traumatic material. And that actually makes the treatment much more efficient and much more effective, much less problematic for the client and for the therapist, because there will be fewer triggerings of traumatic material along that way. So that's one example of why it's important, I think, to have some understanding and some facility with working with attachment insecurity in our work with people. So let me shift to talking a little bit about the treatment approach, both the traditional approach to treatment and the three pillars approach, which is the basis for integrative attachment therapy, which is what I've been teaching and promoting and practicing for a while now. So the traditional model of therapy for attachment insecurity in adults, I like to call the therapist as good attachment figure approach, TAGAF, TAGAF, therapist as good attachment figure. And this was essentially established by John Bowlby, who suggested that because early attachment wounds and developing and the early attachment insecurity was based on problematic relationships, particularly with primary caregiver or caregivers, then the best way, the most sensible way to address that insecurity and those dynamics during adulthood is for the client to have a new and different positive experience with a significant person. And in the therapy context, that significant person is the therapist. So therapist as good attachment figure means the therapist tries to embody all the qualities and the ways of being that we know tend to promote security in children. Now, in my work with Dan Brown, who unfortunately died 3 years ago, we identified 5 particular conditions that tend to support attachment security. So we would say that these conditions are central to the development of security in children, and they're also an important component of the therapeutic process for adults with insecurity. Okay, so the first one is protection, that caregivers, whether it's a parent or the psychotherapist, orients toward providing for safety in whatever the context is for the child or the client. The second one is attunement, that the parent, the therapist, tries to be really and accurately attuned to the moment-to-moment experience of the child or the client, and is contingently responsive, is responding appropriately and effectively to the person according to that accurate attunement. Third is the ability to be comforting and soothing when there's recognition that the child or the client is upset or struggling, appropriately comforting and soothing. The fourth is being delighted by the presence of the other. Obviously, a parent can't be 100% always delighted in the child, but more often than not, that the parent is really delighted, happy to be with the child, not just for what the child does, but who the child is, for the being quality of the child. And that's true in a parallel way for the therapist as well. The more that the client will feel that the therapist respects, likes, appreciates, even enjoys the self in the therapy context, the more beneficial that will be. The fifth condition that promotes security is encouragement for the child or the client to be the best self possible. So it's encouragement for exploration and discovery, trying new things out. This is actually supporting the exploratory system, which exists in conjunction with the attachment behavioral system. The attachment system leads us to orient toward another person. The exploratory system tends to lead us to, hopefully from a secure base, knowing that person is there, we get to explore the world. Now, the world can include the interpersonal world too. So exploration can include getting to know and getting closer with the other person as well. But the exploration and discovery and support of best self is what we're really interested in here. Well, we also highlighted that along with the therapist as good attachment figure, we want to help the client understand the attachment dynamics that have led to problems in the person's experience. This is a kind of a cognitive view, and it suggests that there's value in the client having a perspective, having some ability to take a look at the experience and see experience as experience rather than be fused with the experience and be identified with the experience. So this is a kind of a perspective taking capacity. And in fact, psychotherapy research has highlighted that the enhancement of perspective is one of the components of all effective psychotherapies. Okay, so any therapy, any effective therapy is in some way, along with whatever else it does, is going to be enhancing the client's capacity to have an experience and not be the experience, to be able to take a look at it with perspective. Okay, so relationship and perspective taking. I should say too, in psychotherapy research, the factor that accounts for the most explanation of psychotherapy outcome, better or worse, is actually the quality of the therapeutic relationship. Now, so for integrative attachment therapy and the three pillars, we've built upon this traditional model. So the first pillar of our approach is what we call enhancing collaborativeness. Okay, one of the problems with adults with insecurity is they tend not to be able to have a mutual interdynamic relationship, whatever the context, that involves valuing the self in relationship and valuing the other in relationship and being able to have a mutual interdynamic experience. Now, that can be problematic in the client's relational world outside of therapy, and of course that will come into the therapy context as well. So the therapist paying attention to supporting that relational collaborativeness is a foundational component of this work. So we're very explicit about therapy being a collaborative practice, a collaborative experience, that the therapist has something to offer, the client has something to offer, and together they're going to try to reach the goals that are mutually developed and mutually established. Okay, so that's the first pillar. The second is enhancing metacognition. So that's the perspective taking approach. And this it can involve some very explicit methods. It also just comes into the conversation. It comes into the ways that the therapist speaks. Like, when you said that, what happened inside me was, I felt a little confused. Or, you were telling me about your girlfriend and how she was really mad at you. What else do you think might have been going on with her that day that might have contributed to her being mad? So, or, I noticed that when you said that, your facial expression changed. What's happening inside you right now? So, bringing attention to moment experience, taking perspective on it. Now, the third pillar is what is actually pretty unique and distinct about the integrative attachment therapy model. I mentioned earlier, and I'm sure you have some background with the notion of Bowlby's internal working models. Whatever our experience with caregivers was as children, we have internalized, and as I said earlier, those internalized memories, those representations of our early experience, serve as predictors of what our future experience will be like. I will either trust that my needs will get met by others, perhaps, or I will not trust that. And I will project that internal expectation onto whatever my relationship experiences or my relationships are in my current life. Now, changing Bowlby's notion of the TAGAF approach was designed to create a new internal working model that's positive rather than insecure, that's secure rather than insecure. We think that can work, and we support the TAGAF approach as a context for therapy, as a context for integrative attachment therapy as well. But we think there are limitations to it because the internal working model that an adult has that's insecure is of his or her or their experience as a very young child with an adult parent. The adult client to the adult therapist dynamic is not that. Okay, so the person who has a very good therapeutic experience with a therapist might internalize that, but that internal representation of adult self to adult therapist will sit alongside the insecure representation of the self as child with the adult caregiver. So what we do is, in the context of the positive therapeutic collaborative relationship, we help the client come to, in the moment, experience the self as a very young child. So to go inward, imagine and feel yourself as a very young child in whatever way that occurs to you. And when the client indicates that they're feeling as a very young child, we then suggest that now, through the creative freedom of your imagination, imagine that you're not alone. Imagine it's as though you're growing up in a new and different family, and you have new and different parents who are just right for you, the child who you are. Parents who know how to be with you and protect you, and are so attuned to your needs and are so available to comfort you when you're upset or you're hurt. They're delighted by your very presence, and they help you discover who you are and who you can most be in your best self way. Okay? And so the therapeutic process towards changing those internal working models, the insecure internal working models, involves the collaborative, co-created experience of the self as child having positive attachment experiences with imagined parent figures. So they're creating, through mental imagery, they're creating a new representation that, because it's so similar in form to self as child, self when a child, and adult parent, will actually modify or change or replace the insecure internal working model. And those experiences, the positive experiences with caregivers, there's a very strong somatic approach to this as well. We suggest that whenever there's a positive experience in the imagery, we say, now feel that in your body. Notice what it's like to feel her being so delighted by you. What happens inside your body as you experience this now. And when we bring this to the somatic dimension, that is more closely connected to the self as child's experience when the original attachment experiences were formed. Cognitive processing doesn't really start to develop till the third year of life, but the attachment representations are formed by about 2 years of age. And for the first few years of life, experience is bodily, it's visceral, it's felt, it's not so much cognitive. So much of the third pillar of the integrative attachment therapy work is about bringing awareness to positive felt experience in relation to positive, secure attachment imagery. So, and we find that this is quite efficient. It shortens the therapeutic process time depending on the severity of the insecurity. Of course, that will vary the length of therapeutic time necessary. So if someone has a relatively mild insecurity, or even is secure but has some attachment dynamics that bring in some problems, a few months of work of this really we find to be quite sufficient. Someone who has major trauma built upon or resting upon disorganized attachment, it still can take several years, but fewer years in our experience than just trying to work with the trauma or, say, problematic personality disorders without addressing first the insecurity. So I've just said a lot there. I want to leave time for Q&A and just see where all of this is what it's stirred up in you. So let's open it up now to see what kinds of questions or comments that any of you may have.
Yeah, beautiful. Thank you so much, David. Really appreciate that. Very comprehensive. And yeah, we're going to open the floor. So if you have a question, you can just click the little react button, raise your hand, or you can put it in the chat box and I'll read it out.
And also ask, just as a prompt, perhaps, what about what I've said fits with your experience of working with attachment issues? What doesn't fit? What do you feel excited about? What do you disagree with, and what do you have concerns about? Those can all be framings for anything you'd like to raise.
Yeah, that's a great inquiry there. And I was gonna say, I was like, you were so clear, there was no questions, but it looks like we have a question here. Yeah, Noah, go ahead. You could unmute yourself, ask the question.
Yeah, I think so. When you deal with trauma and attachment styles, is there a specific treatment modality that you like to use to kind of work on uh the attachment style and the trauma and kind of is there a normal, not a normal, is there a typical attachment style that goes along with trauma? And how would you kind of prioritize trauma versus attachment style in therapy?
Yeah, great question, Noah. Thank you. Um, when somebody has attachment insecurity as a very young child, say by 2 years of age, and especially if they have a disorganized attachment pattern because of really problematic experiences with the caregivers. Caregivers maybe were chaotic, maybe unresolved trauma in the parents themselves lead them to have difficulty with caregiving. If the child has disorganized attachment and there's ongoing or even single incidents or few small number of incidents of abuse and traumatic experience, that's very likely to contribute to the emergence of what gets called complex PTSD, complex trauma. And complex trauma, it's called complex because there's a presentation of a whole range and variety of problematic dynamics. There can be depression, anxiety, addiction problems, personality disorders, might even be dissociation in various forms. Okay, and it's very challenging for us as therapists to work with that because there's so many things coming at us, so many different presentations, even across sessions, even within a single session. Where do you start? So I like to start with assuming that when someone has a complex trauma condition, they have an underlying disorganized attachment. And there are ways to assess that. And it's almost always the case. So when it becomes clear that there is that underlying disorganized attachment, most likely, then the therapeutic work would orient toward that and would involve establishing as much as possible a solid and safe therapeutic relationship, a sense of reasonable, that the client would have reasonable confidence that the therapist will be able to be there for the therapeutic process. And then we, once that's established from the collaborative and a little bit of the metacognitive focus, then we can start bringing in some imagery work where the imagined parents would be essentially the positive opposites of the ways that the actual parents were. If the actual parents were hurtful, were abusive, the imagined parents are fiercely protective of the self as child's safety and sense of security and well-being, that they're not going to let anything bad happen to you as child. Okay, and so positive opposites. The parents, if they were actual parents, were chaotic and showed a lot of confusion because of their own unresolved psychological issues, then the imagined parents would be clear and calm and stable and reliable. Okay, so this is the way we would be tailoring the work toward the specific kind of attachment problem or attachment insecurity the person has. Now, when someone has complex trauma and there's a likelihood of abuse that contributed to that, we also want to be quite careful about, say, the bodily focus. Someone who has, say, an anxious preoccupied attachment pattern and no trauma in the history, we can bring a lot of attention to the bodily experience as the foundation for the imagery. Okay, we spend usually 4 or 5 minutes bringing attention and awareness to the felt sense of the body, so that there's more receptivity to experiencing the self as a young child, because as a young child, the body was the central focus of experience. But someone who has an early trauma history, if you too soon bring awareness and attention to the body, that might trigger them. Okay, they might have flashbacks, they might get overwhelmed. So we have to modulate based on our understanding, based on our attunement to the particular client, how to shape the imagery process to best fit the client. One of the objections I've heard to the people who hear about this model, and particularly the imagery approach, one of the objections that has been fairly common until therapists understand the work a little more fully is that, oh, you're just applying a technique. It's just an instrumental technique, like a cognitive behavioral approach. It's not sufficiently relational. Well, I don't agree with that. I actually see that the method, the imagery method, is something that the therapist and the client can collaboratively work with. So it's something that is a focus for the relationship. So relational psychotherapeutic considerations are all important and valuable in this approach. And what we do is we modify the method, we modify how the imagery is presented and worked with according to the particularities of the patient. We don't try to fit the patient to the method. Okay? And that's a really key consideration with this. We modify the method in a relational, collaborative way so it best fits the need of the client. And of course, that's true for all good psychotherapy, I would say. Um, so that's so Noah, that's a kind of a long answer to your question. Depending on whether there's an anxious preoccupied insecurity or say a dismissing or avoidant insecurity, we would modify the method a little bit accordingly as well. And I'll say one more thing about the dismissing pattern. Someone with the dismissing or avoidant pattern developed that pattern most likely because when they were seeking connection, when the attachment system was activated, they experienced being rejected. Okay, active rejection. Oh, mom, I want a hug. Get away from me. Can't you see I'm busy? Too much of that then leads the attachment system to shut down, and getting close will actually be kind of scary. So in the psychotherapy of somebody with a pattern like that, we as therapists actually want to modulate our relational ways of being. If we're too warm, for example, if we're too inviting, if we're too soon suggesting that the person try to allow closeness, it's just going to be scary. The person's going to start coming late for sessions or cancel sessions. It's too much. So the therapist modulates that. And actually, somebody with that avoidant pattern can do very well with the imagery, because in the moment-to-moment experience with the therapist, there's not this intense, focus on each other. There's like a third that both can focus on in a collaborative way. And often people with the avoidant pattern feel a little safer to be in the therapy when there's this sort of method that reduces the experience of intense focus just between the two people in the room.
Thank you, David. We got we got some questions in the chat. There's one question: how does the underlying disorganized attachment present itself in a client? And yeah, maybe because I was thinking this may be a broader is like how does a clinician kind of identify some of these things, especially if they're not like trained in in-depth assessment? How do they identify what the attachment? What are some things to look for? You mentioned some of the stuff with like dismiss. So if they might have had a, story of like, oh, I, try to reach out for connection with my parent, or they're having that in their relationship, right? Like that kind of dynamic. But
Yes, great question too, and very important. Um, the there are various ways to assess, and one the least structured is the therapist who has who develops familiarity with the patterns through study, through experience therapeutically, um, will actually just start to recognize through talking with a client and hearing about their history and their relationship history. We'll start to recognize certain patterns that that give the therapist usually a good enough sense of what the prominent pattern might be. Okay, but there's also on the other end of that spectrum of intensity of process, there are interview-based methods like the adult attachment interview, which takes a long time. It's quite expensive. It's not realistic for many clinicians and many patients or clients, but it's really valuable if it's possible. In between there are a number of self-report measures. And what I'll actually recommend to you is called the Experiences in Close Relationships Scale, the ECR. The latest version is ECR-RS, Relationship Structures. And you can actually find this and refer clients to, you can take it yourself and you can refer clients to take it on the website attachmentproject.com. And if you go to attachmentproject.com, that's not my website, or I'm not affiliated with it, but I know the people. It was actually initially started by Dan Brown and a business partner. But if you go to the homepage, attachmentproject.com, and I think up at the top somewhere it says attachment quiz or take attachment quiz, then you can have an interactive presentation of the quiz, and you'll get a printout. You get a narrative printout and a graphic representation of what your responses to that quiz suggest are your attachment patterns with mother, with father, with partner, and with friends. Okay? Now it takes 10, 15 minutes to take. It's very quick. There are limitations to it. You should take the results with a bit of a grain of salt, but it tends to be very useful, at the very least, for starting or having a basis for conversation with a client. Look, you came out here and this is what it says about that. What do you think about that? And how well does that fit your experience? So it's a good way to start thinking about and talking collaboratively about attachment.
Yeah, thanks, David. We have some more questions. Could sibling dynamics, particularly those marked by resentment due to unequal caregiving or discipline, surpass the caregiver's direct influence in shaping individual attachment styles over time? So yeah, like the impact, the relationship between siblings, and maybe yeah, like the prioritization of one sibling over the other, something like that. Yeah, like how does that play into um, yeah, influencing attachment style?
Yeah, that is an important factor to consider. And um, what the way I think about that is that when there are problematic sibling dynamics, that's usually the result of there being problematic parenting dynamics. If a parent plays favorites, has a favorite child, and that's obvious to the other children, that's going to contribute to a sense of insecurity by the non-favorite siblings, the non-favorite children in the family, insecurity in relation to the caregivers. Oh, well, mom always favored brother, and my brother, and that didn't favor me, or mom always gave extra helpings at dinner to him, and didn't want me to eat more. She always said I was fat, and so, and then that can lead to problems between the siblings, of course, too. Um, I think of a person I worked with, disorganized attachment pattern, was really the scapegoat in the family. Had an older sister, and the older sister was clearly the favorite. And the older sister, seeing the parents being more negative and critical toward the younger sister, who was my client when she was an adult, the older sister also became negative and critical, modeled after how she saw the parents treating that child. And so they developed a very problematic relationship as well, which after some years and after some therapy process for the younger sister, my client, they actually reconciled and have a not super close relationship, but a much better relationship than they used to.
Thank you, David. And let's see. So, for anxious, insecure attachment with a preoccupation of abandonment, how should new romantic relationships be shaped in terms of beginning a new one? So, maybe if somebody knows that they have this kind of attachment style, what would they do to, maybe have a better relationship? Like, say they're getting into a new relationship, maybe they would bring that in somehow. But yeah, what would you say?
Yeah. Well, a component of it, if we look at the second pillar of the work, really is a kind of psychoeducation and perspective bringing, perspective enhancing. So, basic frame of something like, we've identified and we recognize that you have this pattern that's been called anxious preoccupied, where it's hard for you to trust that someone that you want to be close with in your life will actually consistently want to be close with you. And as such, it's likely that you get worried and maybe afraid that the person's going to lose interest in you or going to get interested in someone they meet at work and leave you for a new relationship. And we know that when that happens, you tend to get clingy and you tend to want constant reassurance that the other still loves you and still wants to be with you. So as you're starting this new relationship, let's watch this unfold. let's be aware of your experience as these patterns start to happen. And let's see, as you recognize them more, if there's some ways that we can work with that anxiety, that fear, that worry that you won't have the relationship you want. Let's see if we can find ways to work with that, so that it doesn't actually interfere with the development of the relationship. And so that's a metacognitive second pillar kind of approach. Also in the imagery, the attachment imagery, having imagined parents who are stable and reliable and reassure in effective ways that the self-as child is valued and is loved, that also will contribute to more security as this new relationship develops.
Thank you. And this is an interesting one, and this might be also related to trauma. But in integrative attachment therapy, how would you go about treating clients that have experienced loss of a parent caregiver in childhood, whether that be through death, abandonment, or family separation?
Mm.
So yeah, is there a difference of working with something like that than in a case like where the parents are there but just not given adequate care, where it's like a parent left or a parent maybe died?
Yeah, well, the key is working with whatever the experience the client brings. So um, if it's interesting, John Bowlby, who's the father of attachment theory, uh, his 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 most well-known writing, which was a convergence of all of his research and thinking over the years, it's a trilogy of books referred to as Attachment and Loss. Okay, so loss is considered to be really central in attachment experience as well. He drew from that from personal experience, because while his fairly aristocratic British parents were not very available to him and were kind of cold, um, he had a nanny for the first 4 years of his life who was warm and welcoming, and he had a really secure attachment relationship too. Suddenly, that nanny I think she was fired, or she suddenly wasn't there anymore, and a new nanny was brought in who was actually not very warm and not security enhancing. So Bowlby had this experience of loss, significant caregiver, his most significant caregiver, and so we would work with that as uh, contributing to probably an expectation when a person starts to feel close in connection, an expectation and resulting fear that there would be loss, that the person would go away. Now, as in the therapy, we can't promise that relationship won't go away, because it might. Person may leave, may die, may, something. Um, so we work on helping the person process the grief of the actual loss, because grief often comes up in the context of this work because loss is fairly common. So we do grief work. Grief, we hold that as part of an important element of the therapy work. And go ahead. And then in the imagery, we would, as a person starts to get close with an imagined parent figure, then and there'd be fears of loss coming up, then that would be worked with in the imagery as well.
So there was another question about scripts and resources available for guided imagery, and I believe that I have some links somewhere for Dan Brown. He had some guided meditations for the ideal parent protocol, but I don't know if there's any other resources that you could recommend or point the clinicians to.
Well, I think probably what you're referring to, Artem, is it would be the best to point people to. You can find it on YouTube if you do a search for Daniel Brown and ideal parent figure.
Mhm.
There are a number of examples of ideal parent figure process on the internet. I don't endorse quite a few of them.
Mhm.
Um, uh, but the one that Dan presents, I think, is quite good. You'll experience it as rather like a lot in a short amount of time. He was kind of doing it fairly quickly as an exemplar of what the process involves. If you listen to that or follow it or take it as an exemplar, please hold the perspective that you wouldn't want to just do that verbatim with any of your clients, because you want to fit the approach to your particular client. But Dan packs a lot into that, that one example, that you probably wouldn't do as with any single person all at once. You might spread it out and do different elements of it over if you're actually doing a therapy with somebody. So use it as a guide, use it as some information to learn more about this. But if you're going to apply it, think about how you would make it your own. Okay? Let me also just highlight, I mentioned websites and searches and all that. If you want to learn more about integrative attachment therapy and some of the training that we have for that, integrative is the website to go to. Currently, the page up there is about an online training course that we have. I think this week, actually, the website will be updated so that there'll be a more comprehensive website that will include that current page as a page in the training section. But integrative-attachment-therapy.com will be a resource if you're interested in more.
Thank you so much, David. Really appreciate you, and I'm glad you brought up integrative attachment therapy. Like gave the link. I'm gonna provide all the links and everything we spoke about as resources in the show notes when I upload this to YouTube, so everybody will have that. David, thank you so much. Really appreciate you coming on. I'm getting a lot of comments here in the chat that people thought it was an excellent presentation. So thank you so much.
Well, thank you, everybody. Thank you, Artem, for organizing this, and thanks everybody for your interest. And we may encounter each other in another time, another place someday. So
Awesome.
I wish you all well with
Yeah.
your work and yourselves.
Thank you.
Thank you.
Take care. Bye.
Thank you.
Thank you.
Thank you. That was great.
Thank you.
Thank you.